Well, ladies and gentlemen, we're going to move now to a discussion about the value of palliative care at the end of life, and we're going to use as a trigger for discussion, we don't have to be confined to it, a story. And on many of the seats is a sheet of paper. If you can find one, it's got panel discussion, caring for older people at the end of life. What difference can palliative care make? And just before I read it, just a couple of facts that I've been given. 32% of Australians die in residential aged care. That's the Grattan Institute's submission to the Victorian End of Life Choices Inquiry. So 32% of Australians die in residential aged care. Also, the Victorian End of Life Choices Inquiry report included these two recommendations. Recommendation 6, that the Victorian Government work to reduce inequities in the provision of palliative care by ensuring consistent palliative care services across residential aged care facilities. And 7, that the Victorian Government work to prevent unnecessary emergency department presentations from aged care facilities and reinvest any savings into palliative care. So that's sort of a context. I'll just now read the story and then I'll introduce each of my panel members as we come to you. Mary is an 82-year-old widow living alone in regional Victoria. She has 2 children with family responsibilities. Her eldest child, Colin, lives in Melbourne and Claire lives in the next town. A neighbour visits Mary and finds her with severe breathlessness, a fever and too weak to walk. She's taken via ambulance to the emergency department of the local hospital. Mary has had several emergency hospital admissions in the last 18 months due to her chronic obstructive airways disease. She also takes medications for high blood pressure and angina. Claire and Colin visit Mary in hospital. They tell staff that Mary is fiercely independent. She had a very good relationship with her GP until his retirement 6 months ago, and since then has been seeing locum GPs. The hospital staff have noted that Mary is forgetful. Claire says a locum GP noted Mary's forgetfulness and confusion, but no tests were done. Mary has not appointed an enduring power of attorney, medical treatment, or documented her end-of-life care wishes. Claire says that Mary spoke to her GP several years ago and told him she wanted everything to be done to keep her alive, except if she had dementia. Mary also said she did not want to be given morphine as she felt this had hastened her husband's death from lung cancer 10 years ago. The doctor advises Colin and Mary that they should not be surprised if Mary were to die within the next 6 months, as her condition could deteriorate at any time. Colin and Mary have different views about whether their mother has dementia and therefore whether she should receive active treatment. An aged care assessment is recommended by the hospital. Neither of the children are comfortable with her being discharged to aged care due to their concerns about their capacity to provide the care she needs. Colin thinks she should stay in hospital and requests a referral to palliative care. Claire would like to care for her mother at home, but her family situation makes this difficult. So there's one very small plot development I'll bring in later, but look, I might, if I may, I'll come to Rosalie Hudson first, please. Can you take the microphone, Rosalie? And Dr. Rosalie Hudson is Associate Professor in the School of Nursing and Social Work at the University of Melbourne. She's a consultant and educator in aged care and palliative care, and she, in her history, has spent 12 years as a DON, the Director of Nursing, and she's worked in all kinds of settings, including as an educator with Alzheimer's Australia. Will you give her the clap of encouragement? Can I just ask you, as you look at that set of facts, what do you see as the critical issues that go to the future of Mary and the quality of her life?
I think
really close to your mouth. Yeah.
The distinct absence of Mary's voice from that scenario is the first thing that rings alarm bells for me. The other alarm bell is, why has she not had a definitive diagnosis for her forgetfulness? Too many GPs, in my experience, treat such forgetfulness as just a bit of old age forgetfulness, love. But actually it should be a direct alert for a proper comprehensive diagnosis to establish whether it is dementia, and if so, which type of dementia, because that's crucial to the ongoing treatment. The other issue that rings alarm bells for me is the fact that several years ago she had a discussion about her future care. That now needs to be revisited urgently so that her future care can be determined.
Revisited in what way? What do you mean?
Well, I would suggest an urgent family meeting with Mary present, and I take it that this is while she's still in hospital. A family meeting with Mary present, palliative care people as well, so that Mary can outline what her wishes are, particularly as to whether she wants to avoid another emergency admission. We already know she's fiercely independent, so the various scenarios about her future probably would not be appealing to her, but we don't know because we haven't heard Mary's voice.
I'll come to the question of how we might determine Mary's capacity and get her point of view in a moment from a legal perspective, but the son in this story is presented as being anxious that residential aged care would not be able to provide the right care for his mother. What would you say to that son if you were talking to him?
Well, I would appreciate that those fears are very, very well founded. While I have direct experience of a number of nursing homes that give excellent end-of-life care, I also have knowledge and experience, as many of you would, about many nursing homes which feel that they don't have the capacity to provide such good end-of-life care, especially when there are so few registered nurses available 24/7. So that's why, and I don't know whether you want me to elaborate on this now, why I would be advocating some form of collaborative relationship with the regional palliative care service, because we shouldn't assume that Mary needs to be receiving specialist palliative care. If she's able to go into a nursing home, her care may need to be augmented by some specialist services.
For time reasons, I'm not going to confine myself just to the story, and I'm going to ask a direct question of Rosalie Hudson, and that is, you passionately believe it is possible to improve the capacity of staff in nursing homes to deliver palliative care if there's more collaboration. Tell us what's got to happen to make that a reality, so that you'd put your own mother or even yourself into a nursing home.
Well, I can give you a direct example, which I was personally involved in. A large group of nursing homes across Melbourne metropolitan area realised that they needed to have more education in end-of-life care and palliative care. So they got some funds and they made it mandatory for every staff member. That included cleaners, domestic staff, right through to admin staff, as well as all the health professionals. It was mandatory for them to attend a 2-hour education session on palliative care. So over a period of 12 months, every single staff member received a 2-hour education session on palliative care. The result of that was that their idea and understanding of palliative care, of course, was raised 100%. And then as a further outcome of that, the staff themselves wanted to avoid their residents being sent to hospital unnecessarily. So as a direct result of their education in palliative care, they were able to reduce those the unnecessary hospitalisations over the next 12 months to 98% of their residents died in the nursing home, whereas previously many of them had been sent to hospital where they died, which was against their wish. So the emphasis, of course, is on education. That requires time and money and effort, but this is an example of where it was put into practice and it worked.
And is it really possible to offer high quality care without registered nurses, let alone access 24/7 to clinicians with expertise in palliative care? That's a genuine question. I hope no one finds that offensive.
Well, I think that we do have the experience of many nursing homes, as I said, who at present, without a registered nurse or without more than one registered nurse, are able to provide good quality end-of-life care. For example, personal care attendants, if they receive the adequate education and if they have some support. Now, obviously, and it's a scenario that I personally disagree with very strongly, given the nature of residents in nursing homes and the fact that most of them have 4 or 5 comorbidities which are incurable, and each one of which fits the criterion for palliative care, and yet we don't have health professionals to provide the proper care. That's the reality. But also the reality is we do have some very good personal care assistants who, with the proper education and support, can provide care. Not everybody who's dying in nursing homes needs specialist palliative care.
That point that you made, though, about the percentage of people who could say needed palliative support was made by an early questioner who basically said, why isn't it just normal operational business in all nursing homes? And can we avoid the proposition that we don't value our old people and we're not prepared to spend the money on it?
Well, I think there's probably 2 parts to your question, Julie. I think the one concerning the quality of care that is given to people in our nursing homes, there should, I firmly believe, be a much greater emphasis on the comorbidities that I just mentioned as evidence that these people require expert end-of-life care. And it's not going to be the quick fix of 3 days of palliative care before death, but it's likely to be from the day of admission. And I think the sooner we can get that message across, that palliative care is not for the last 3 days of life, but a palliative approach. We've had the guidelines, the government guidelines of a palliative approach to residential aged care since 2006, which quite clearly state that all residents in nursing homes require a palliative approach. Why? Because they have 1 or, if not 4 or 5, diseases that will end in death, probably within 12 months. And that is the criteria for a palliative approach. That, I believe, and nothing less, should be offered to every resident in every nursing home.
Look, thank you very much. Would you give her the clap of encouragement? I'd like to introduce Phil Grano, OAM, Principal Lawyer in the Office of the Public Advocate in Victoria. Just in a nutshell, what that means, the Office of the Public Advocate?
The Public Advocate is a person, the Colleen Pearce, who...
Can you point it at your mouth?
Sorry. Yeah. The Public Advocate is Colleen Pearce. She is appointed often as the guardian of last resort for people who have lost the capacity to make lifestyle decisions for themselves. So sometimes those lifestyle decisions could be around medical treatment, and they could be, at times, the tribunal may appoint the Public Advocate to make decisions about ceasing life support.
Phil, what I'd like to do is to ask you a series of rapid-fire questions and get concise, lawyerly answers so we get the law out of the way but feel we've done our duty. Are you ready, brother?
I hope so.
So, going back to the scenario with Mary, has Mary got capacity? How do we decide? How does that happen?
We don't know whether Mary's got capacity because, as Rosalie said, we don't know anything that she said about anything. We know that Mary has a certain forgetfulness, but we don't know what that forgetfulness is, what degree it is. So if you're going to test Mary's capacity, first of all, you've got to start off, what's the decision that needs to be made? Capacity is decision specific. So is it about the care? Is it about what particular care? Is it about medication she's on? Does she have the capacity to make a decision about a particular medication? All right. Then you'd say, well, does she understand the circumstances? So the first issue is understanding. Does she understand the treatment? Does she understand what is involved in the treatment and what choices she's got and why she's got them? The second aspect of capacity is remembering. Can she remember the information for long enough so that she can weigh it and use it. So the weighing and using of information is the third element of a general capacity assessment. And that's important because you've got to evaluate the information, and so you can say, yes, I need this medication for this purpose, and this is what I should do. And the fourth thing is, can she communicate it? And that's, again, the fourth thing that we don't know about Mary, is whether she can communicate any decision that she may make.
Let's imagine this is an entirely sensitive family and professionals. Can you hear me? Yeah. And they decide she has the capacity to make some decisions, but there are one or two decisions that are really important that she doesn't have capacity to make. Who is responsible legally for making those decisions for her on the set of facts we have before us?
That's a very complicated question on these facts, because if the decision is about, for example, whether she's going home or not, then neither her son nor her daughter would have the authority to make a decision that she should go home, contrary to any wishes which she has. So you would have to seek the appointment, in Victoria at least, of a guardian to make that decision. That is, if she's unable to make that decision for herself.
Could I just ask you, what is the name of the legal instrument in Victoria that you can complete in advance with a solicitor to say whom you would want to make decisions about where you live and your medical treatment should you lose capacity? What's that called?
It's a power of attorney for personal matters. You can make a power of attorney for financial and a power of attorney for personal matters in the one document since September last year.
And is the enduring power of attorney medical treatment a different one again?
It is indeed, and it's only, as it says, for medical treatment.
It's just, well, I'll put it to you as a question. If you were working with lots of older people who were likely to lose, well, if you were working with anyone of any age who was an adult in Victoria, would you encourage them to have all those documents in place? A power of attorney for money, a power of attorney for medical treatment, and an enduring, what's it called?
Enduring power of attorney medical treatment and just an enduring power of attorney. There are 2 documents now. We used to have 3.
Okay, so you can make one that just has money and
personal matters, so that's 1 power of attorney, and you can have a power of attorney medical treatment.
We need to get, it's different in New South Wales, so it's where I'm from, we also need to get national agreement on this because everyone's so mobile and you could think you had yourself covered, move for work, have a car accident and you're in trouble.
Some states have mutual recognition of these powers now, so that does help, but not all states do. And during the week someone asked us whether a power made in the UK, an enduring power in the UK, would be sufficient, and it's not under our law in Victoria.
I'm not going to go into every fine detail. I think would you agree that getting those documents in place for everyone in this room and everyone they know is a good idea?
Mostly, yes. I think it really does depend on a person's circumstances. There's not much point making the appointments if you don't appoint the right person and for the right reasons and give the right instructions. So you could say yes as a general rule, but if you don't have people you trust, then you'd be better off not making the appointments and having an independent body make the appointment as to someone who would be the best position to make those decisions for you.
How much weight should be given to Mary's views expressed to the former GP years ago?
Very difficult question because they are views, and in the absence of current views, you would have to give them some level of credence. They were made at a particular time. They were made a long time ago. They weren't made with her knowledge of her current circumstances. That makes them very difficult to judge. What I think is really lacking in this story is Mary, just because she may have lost capacity to make a decision, doesn't mean that she's can't express a view or a wish. And I think here, there's nothing in the story that says that she's unable to do that. Under guardianship principles, even a person's wish has to be given effect to wherever possible. It can't be ignored.
Thank you very much. Could I come over now to Dr. Karen Hitchcock, who's a consultant physician in general medicine at Alfred Health and the author of a quarterly essay, Dear Life, on caring for the elderly. Just in a nutshell, what were you exploring in that essay, just for people who haven't read it?
Oh, goodness, a nutshell.
Put it close to your mouth and project your voice.
I guess I wrote that essay out of a sense of fear and sort of desperation at the single story that I was hearing from the media and from various activists within the hospital and from government, and that was that the main problem was overtreatment, and the main problem was keeping people alive against their will. And actually, I was seeing on the wards the opposite of that there was sort of a horror at people's desire to keep living their life of, with their four-wheeled walker and, people actually valuing their life, even though to a 35-year-old triathlete it might be this hideous existence and they couldn't. So I just, there had been a big movement in amongst certain quarters in certain hospitals to have roaming trained communicators going around the hospital independent of the treating teams, getting people to sign advanced care directives, and that was, I heard, going to be rolled out, and I just thought that was problematic. And so
what was your fear? What was your fear?
Well, my fear was that I work on a very busy general medical ward with the most vulnerable people in our society, people who are very prone to feeling worthless and burdensome. And my fear was that sometimes offering people death can play into their sense of worthlessness, and that they accept that because they don't want to be a bother to people. And I had patients apologising for taking up beds, saying there's someone else who should be in this bed. I had, this week, for example, in the last 7 days, I have had 3 patients admitted onto my ward who an overnight registrar had aggressively told the family that the patient is dying, should be sent back to the nursing home, and the patient's family were, sort of dumbstruck and insisted on the patient staying, and they survived. And what was in the admission notes a bed-bound mute person turned out to be someone who had an expressive dysphasia from a stroke, perfectly good organs, and just able to only walk 30 metres, who loved their family and whose family adored them and visited them every day. And so like the story that you get in a grab is very different from a story that you develop over a day or two, and it's just easy for us to push our assumptions onto families and to patients, and it just made me nervous that we were going ahead with this black and white notion that if everyone fills out an advanced care plan when they're 20 years old, that's going to be right, and they're going to be protected forever, and this is the way to go, and we'll save so much money. It made me nervous. So I, with that sense of fear and anger, wrote this quarterly essay, and then had constant anxiety attacks for about 12 months after.
I commend it to you, Dear Life on Caring for the Elderly. That's what it's called, isn't it?
Yeah.
Can you be even more specific on your fear? What is the fear? Because there is a...
okay, so I don't know if I can be more specific, but I think that...
the impression I get is that you think that the intense promotion of advanced directives could be a tool for people being denied reasonable and effective treatment when they could in fact survive and bat on.
I guess my basic stance is that I think that we have a very strong vein of ageism in our culture. I mean, I can give millions of examples, a parliamentary inquiry into young people in nursing homes, how outrageous. It's my 51-year-old, acute brain injury daughter is stuck in this nursing home, can't decide when she goes to the toilet, can't go outside, no one visits her, has to eat when she's told, etc., etc. And, you know, everyone's like, oh, that's disgusting, we should improve that. But it's like, well, why is that okay if you're over 65? You know, it's like, we are ageist, absolutely ageist. And so that was, I guess that was my first fear. And then the second one is that I see constantly people change their mind. I mean, even young people who are undergoing chemotherapy for, you know, whatever cancer they have, if you ask them during, you know, mid chemo cycle, would you ever want an operation again? They're like, oh, would you just kill me now? And then, but you know, 4 weeks after they've finished vomiting their guts up all day, they're like, yeah, okay, I can cope with that again. And the same thing happens with patients in acute hospitals, and the whole idea about getting someone to sign an advance directive whilst they're sick in hospital, I think is flawed, because many studies show that people up to 2 months after hospitalisation do not ever want to go into hospital again, and after that they're like, yeah, I could cope, you know, maybe I do want to go into hospital. We have this myth that as individuals we're unified and constant, and that the me here sitting with a microphone in my hand is the same as the me in 40 years with aching joints and, you know, dizziness when I stand up and not able to leave my letterbox. But who knows what that Karen Hitchcock in the future is going to decide. What right do I have? That's a stranger to me, and I really think that it's really convenient for us. It quells our anxiety to think that this is the answer. All we have to do is focus on our individual human right to decide now what we want in the future, as if I am the same as that person. And I guess that's my, you know, I don't know what the answer is.
If I could just jump in there, because my job as a facilitator is to drive us towards recommendations.
And to interrupt me because I talk too long.
Two things strike me. Firstly is, and this has been mentioned already in our conference, the focus on the individual, that people are really different. And so some people, so it's not about making assumptions when you meet the individual about whether they want to be in a nursing home, acute care or home. You have to spend the time to get to know them and to try to understand their wishes. And the other thing is that as we go down this road of trying to get everybody to document their wishes, that reviewing the documents is part of the message, that you have to keep updating them. We tell that to people about wills for their property, but we have to emphasise it now in relation to decisions. If I could give a quick anecdote that I shared with Odette, when I was told I had stage 4 throat cancer, I was a radio broadcaster, and I knew my doctor knew that, and I had an instant fear that they might, I don't know, not remove as much of the cancer as they needed to because I might not be able to speak. I had no founding for that fear. That's just what ran through my mind like in a flash. And so I immediately said to him, if you need to take my voice for me to live, take it. And he said in a really serious voice, thank you for letting me know that. That's important. And I realised I just said something profound. But what the point of this anecdote is, if you'd asked me even a few weeks before, would you be prepared to lose your voice in order to survive? I'm not quite sure what I would have said. But faced with a stage 4 cancer diagnosis, I think I would have said, take the head. You know. That was a joke. Thanks for laughing. But I mean, the point of this is, I guess I'm affirming your point, is you cannot anticipate fully until you're in the shoes. And that makes this advanced planning tricky.
It does. It makes it tricky, yeah.
Will I read you the sequel, just so I feel I've done my duty? Mary is discharged the following week to a local aged care facility. It has a registered nurse during the day, but no nursing staff on duty at night. The aged care facility relies on medical support by patients' GPs. 4 days later, Mary suffers an acute exacerbation of breathlessness. Late at night, her locum GP is called and tells them to call the ambulance. Mary is rushed to emergency. And the question we're asked to consider is, how could this situation have been avoided, and how can we help to strengthen palliative care and end-of-life care in the aged care system? Could I just begin with you, Rosalie? Do you see that trip to the acute care hospital as necessarily a failing of the system?
I think that if we go back to
Mary's...
Mary's...
I'm just having trouble hearing.
If we go back to Mary's story, she has had repeated admissions to emergency, and I think we all know of repeated admissions from nursing homes to emergency departments that may have been prevented. I'm not suggesting that every one of them was unnecessary and should have been prevented, but if it's the wish of the person not to be hospitalised but to be cared for in the place where they currently reside, then everything should be done in order to keep the person there. If I can use another example, the example of collaboration between a nursing home and a regional palliative care service. This was a gentleman with end-stage COPD. He did not wish to be hospitalised. He wanted to remain in the nursing home as his families wanted him to remain there. So what were the night staff supposed to do if he had an acute exacerbation of breathlessness at 2 a.m? Well, the answer was to develop a crisis care plan. This is what you do if Mr. A has a severe episode of breathlessness in the middle of the night. And a step-by-step plan was drawn up in collaboration with the GP and the local medico from the palliative care service. The GP said, I am incompetent to really do anything in this situation. I would advise hospital admission. Now, the GP is not going to be phoned at 2 a.m. It's going to be a locum. And the nursing staff at the nursing home, or whoever's on duty at night, ought to have the reassurance and the courage to make decisions on the fact that they know the resident better than any local medical officer. And on the basis of their knowledge of that resident, they should do everything in their power to prevent hospitalisation if that's the person's wish. So back to the story. The palliative care physician came to the nursing home, met with the GP for about 15 or 20 minutes, helped to develop a crisis care plan to work out what pharmacological and non-pharmacological responses would assist this person's comfort. And at the end of the 15, 20-minute collaboration, the GP said, I'm right now, I've got it. I was scared to give him morphine because I didn't want to depress his respirations. Now you've shown me the proper dose to use, I'll be right next time. So that crisis plan sat in the front of the resident's file, and he was saved other emergency admissions, which would have been against his will. And by this stage now, he had end-stage Alzheimer's disease and was unable to express his own view. So it had to be in writing on his behalf. And I think, as the report that Julie referred to before emphasises, if we can save money from unnecessary emergency admissions from nursing homes to acute hospitals, then we can save that money and plough it back into palliative care services, who then can meet with GPs who may not necessarily be competent in end-of-life care to ensure that that can happen where the resident is and where the resident wants to die.
I'd like to have a quick comment from each of you, and then I'll open to the floor. What's your view of that set of circumstances and what Rosalie said?
I guess... Gosh, I have a million thoughts all at once. It depends, what are they going to do in the hospital that they could not do in the nursing home? I mean, it may be, it's not a choice of, death or not death. It's is there something reversible? Do they need to be in the hospital to have that treatment? Would a mobile chest x-ray and some antibiotics get the person over that exacerbation of their COPD? Is it just symptom management, which is not to do with life or death, but just to do with making the patient comfortable, and it's not going to hasten their death? I mean, I think that as physicians now, we cure very few diseases, actually, and we are in some ways palliative physicians. I mean, my job is constantly with my heart failure patients or my emphysema patients.
See when you can hear your own voice? That makes it easier for people.
Sure. My job is constantly to be focusing on ensuring the highest quality of life and the least treatment burden possible. And I mean, that seems to me to be what a palliative care specialty aims to do as well. So I don't think that we can say it's necessarily a bad thing for people in nursing homes to go to a hospital. Sometimes they must go to a hospital for treatment, but there's definitely things that we could be doing in the nursing home if we had the adequate infrastructure. At the moment we do not, and so I therefore think that it's very dangerous for us to be promoting to all junior medical staff that if somebody comes to the emergency department from a nursing home, they're a GOMA, get out of my emergency room. That I think that there's problems with that.
Is that an expression?
It's from the UK. We call them crumbles. And
what do you call them, sorry?
Crumbles or, I don't know, bed blockers or...
You see, may I just speak my fear, and Sarah, I'll give you a chance to... But my fear is, this is just a fear. It's late in the afternoon. I might be wrong and I've got a cold. But my fear is that we've got a very mixed picture in aged care, and some of it isn't where any of us would really like to live. I'm fully aware we'll all have lots of people in this room who've got family in nursing homes, and I've had family in nursing homes. But let's be honest, it's a mixed picture. We've got inadequate staffing, so you've got people overnight with no registered nurses. And I've been to other conferences where every quality of life issue for a patient is dependent on the registered nurse staff patient ratio, isn't it? There's tons of evidence on that. So we've got a whole lot of really sick people without a nurse. Oh my God. And so then we get this kind of culture going that, oh, why do we keep taking them to the acute care hospital? Burning up resources. Look at the quality of life they've got that we've created for them. We're delivering it to them on a daily basis.
Exactly.
Who want to live like that? Exactly. You see my fear?
Yes.
I think there's a trend there that makes me think there'll be a royal commission in 30 years that'll look back and say, whoa, what the hell did they think they were doing? That's my fear.
I agree. I totally agree.
And I am driven, like this is anecdotal. We all know anecdote is the enemy of evidence. But I can't tell you, my mother is a frequent flyer. She even got very clever at because we haven't got the electronic health record together. She knew that going to 3 major teaching hospitals in the Sydney metropolitan area, as long as she didn't mention she'd had an admission down the road only a few weeks ago, they'd start a whole new set of tests. I'm not saying this is good or bad, but this is a woman who used to say, I'll go by taxi, because she knew the ambulance. Well, she got sicker and had to go by ambulance, so I won't go into the whole tale, but let us simply say, Mum liked admissions through accident and emergency. She liked the young doctors asking her all those questions. She liked the whole goddamn experience. And she went for years enjoying it. She's 91 and she's still alive, and a lot of care at home, and now she doesn't like it so much. And now there's a really great system where sometimes the ambos still come, but they've got a new system. They know her. Once they realise she's not actually dying, they go, and another ambulance comes with a guy who stays for a couple of hours. It's some sort of local strategy to prevent unwanted admissions. But my final anecdote is, I'm going back a few years back now, I'm in an intensive care unit. My mother's in the bed. The doctor's here and he's having a conversation with me. And I'm listening to him, and I said to him, while I'm listening to him, I'm watching my mother. In the background, my mother has motioned to a nurse. She's intubated. She's still managed to convey that she wants a bit of paper and a pen, and she's writing things down. So I'm watching that while he's talking to me, and I concentrate. I said, sir, are you having an end-of-life discussion with me? He said, yes, I am. Your mother's very, very sick. I said, let's both turn around for a second. So we go over to the bed, and Mum was writing out her medications because she's seen so much in the paper about, people die because they get the wrong medication in hospital. Intubated, she's writing it. So 3 days later, I'm visiting Mum in intensive care. She's now sitting up eating, and the doctor comes over and he had the good grace to say, Lassie, you were right. So I know that's just anecdote, but my mother's a really assertive person, and she's got money. Yeah. No, you know what I'm saying, guys.
Yeah.
And I'm worried. I'm worried if we don't focus on the individual and really exploring their capacity and really exploring their wishes, you know, are we shoving people a little bit too quickly into nursing homes and not calling the AMBO when they need it? That's my fear. Is it misplaced, Mr. Law?
I could revert to anecdote as well. I'm an attorney for a woman who's was my former neighbour, and she's in a nursing home. And she's been there 5 years now, and she's on her 3rd advanced care plan. And every time the nursing home has turned to me to have the discussions with her about what goes in the plan. And when she first went into the nursing home, she'd recently been in hospital, and so she said, I don't want to go to hospital. It's been 2 years later, we reviewed it, and she said, I'm not so sure now. She'd seen other people in the nursing home go to hospital and come back. So they seemed to be okay. The last one, she said, no, I think if the doctor thinks that, you know, they haven't got a diagnosis and they think I can benefit from hospital, and I'll go to hospital. And she's 96. So I think what I've learnt about that, and I think it's conveyed in the parliamentary report, is that we don't know how to have conversations about this. The nursing home didn't know how to have a conversation with her, and I'm not sure I was very good at it either. I mean, we used to go out and have cake and coffee, and we still do, in fact, every weekend. And we'd have the conversation over cake and coffee, but that it is really difficult to have these conversations, and I'm not sure.
And people change their mind.
And people change their mind, and you know, they don't want to bind the future self at one level. They want to, all things being equal, they'd like someone to make a decision at the time. I think that's what this. So, should Mary have gone to hospital? Going back to the story, I thought, well, if they did something for her, she was terribly distressed in the nursing home. They didn't know what to do for her. What choices did they really have? I mean, it seems they didn't have an advanced care plan as to what to do. They didn't have, as you were saying, this emergency or crisis thing. Well, bloody hell, why should she be left in such distress? What can you do? And it's not said that Mary died as a result of going to hospital, so it was a beneficial thing.
Rosalie, do you want to make a final comment, or will I go to the floor? Because obviously I've got to go to the way forward in a moment, and I don't want to do that simplistically. What we're showing is complexity. Who'd like to either make a comment or ask a question? Because you guys are dealing with this in real time. Can you yell if I can? Did you raise your hand? Yeah. Sorry, just the light's in my way. Can you introduce yourself?
Kate Munro, I'm from New South Wales and the Hunter. I loved your paper, Karen. I thought it was brilliant. But I want to working in acute settings is where I'm based. And I'm sorry, but we get people who come in from aged care from home, and our teams love them because we get respiratory, cardiac, you know, gastro, who all have a go. So it's not that, you know, people don't know what they want or can't make decisions. It's we as healthcare providers don't always stop and say to the person, what matters to you? What's important to you? So we're not always very good at it in the acute settings either. I just thought I should kind of throw that in. But one of the things that we do in the Hunters, we have a program called the ACE program. Because in New South Wales, we are getting in a very terrifying space where we are getting limited, if none at all, RNs in our aged care facilities. It's actually quite frightening. But we have this program where someone from the aged care facility can ring our ACE team on...
What does it stand for?
Aged care emergency. So basically they can ring, an assistant can ring a registered nurse and say, look, these are what are happening, should we call an ambulance? So it's an interference, I guess, in the sense of the nurse will assess, yes, I think this is critical, let's call an ambulance. Or they'll say, no, I think if you do this, this might settle the patient, you can try this. essentially, I'm sure it started because of economics, trying to stop people coming into EDs. But in actual fact, it's proved very beneficial for the nursing homes. And the residents in nursing homes feel like they are actually valued and they're important and they're not dumped into an ambulance just because they don't know what to do. And I can just say, language is really important. And I loved what you said about your fear about these aged, advanced care directive people coming around. I think in health we use this language that is terrifying. Because like you say, I don't know what I'm going to want, but I know what's important to me. Like I know I might want to eat ice cream every day. That might be important to me. But I don't know if I want antibiotics because I don't know what I'm going to look like when I get down the track. And one of the things that we're not good at is engaging with our healthcare professionals like GPs called, okay, so I've got COPD. In 12 months' time, this might be what your life might look like. So talk to your family about, do you want oxygen at home? Do you, we can actually engage in those kind of conversations in a non-frightening way that let people go and chew on stuff and think about it and then make decisions.
Thank you very, very much. Thank you. Well, I just see if there's any other comments like that or questions, just see where the audience is at, and then I'll come back to you. Did you raise your hand?
My issue I have...
Would you just introduce yourself?
I'm Janine Benson. I'm a district nurse at Hess Rural Health Services in Winchelsea, and I'm also a palliative care nurse at a self-funded hospice in Colac. And my issue I have is that, having been around as a nurse for 30 years, that a lot of the private nursing homes will not pay for their staff to be educated, and not all education is free for palliative care. Also, they don't allow for the time for their workers to actually do these courses because of cost of their replacement, etc. And the other thing I find too is it's all great to say you need to have an enduring power of attorney, you need to have a will. Why is it that it costs so much to get it done? It shouldn't cost as much as it does for the tiny little bit of paper that a secretary types up after you've given all your details to your solicitor. And that's what I find is why a lot of people don't do them, because of cost, especially when they're pensioners. It's like every dollar they should get it at really subsidised prices. And and like I said, education is a cost, and until we address the cost of things, it's not going to get any better.
Thank you very much. I'd like to come, if I may, quickly to Rosalie on the education matter and then to Phil on the law matter. So your response to that sense that there are private residential aged care services who just will not provide time and funding for training?
Look, I'm very, very, very much aware of circumstances like that. But where there is a will, there is a way. And other places have actually been able to obtain funds from a variety of sources, from the local community, when they've put the issue out there as requiring urgent attention. Funds have been made available. I can't go into all of you, would have examples from your own experience. But am I allowed to go into the way forward?
Yes,
what I would see as one way forward, and I know this happens in some areas already, regional palliative care service collaborating with the nursing homes in their area. Now, I know some of you already do this, but I think where this happens, it results in a remarkable opportunity for nursing home staff to draw on the skills of palliative care staff. And just a quick example, when I was raising this question with a group of registered nurses recently, one of them said, oh, well, I was on the other night and we had a crisis, and I thought, oh, well, I'll check with the palliative care, and all I got was their answer service. Well, now that's not good enough in my view. Every nursing home should know how to communicate with their regional palliative care service, and it may mean manager to manager sitting down for 30 minutes and drawing up a protocol which says you can contact our service for these reasons at these hours. And then that makes it clear to the nursing home what advice, they may be able to receive from specialist palliative care services. As I said, not every dying person needs a specialist palliative care service, but where the nursing home is really floundering because of their lack of staff, lack of skills, lack of experience, and where the resident doesn't want to go to hospital, they should be able to draw on the advice, even if it's a phone call to the regional palliative care service, but they need to know whom to call, at what hours, and what advice they can expect. For example, with a COPD query, I heard recently of a staff member in a nursing home seeking that advice from the local palliative care service, and the answer was, well, if it's emphysema COPD, that's not end of life and it's too early for us to be brought in. Now, I understand the difficulty in resources in the specialist palliative care area and the movement over time from being a specialised service for people dying of cancer within 6 months, and now it's broadened and it's difficult. And I know the lack of resources in specialist palliative care, but I also know of examples where it works really well, where a specialist palliative care service forms a very, very active partnership with the local nursing homes, and it works to the advantage of the residents.
I'm just going to ask a quick question to the others and I end. I promise I'll end because we're at the end of our day. Just on that issue of cost of the documents. In New South Wales, there's a major public trustee program at the moment called Planning Ahead, and they're whizzing around the state in buses getting people to do these documents. Is there any such program here so that poorer people can do this?
Not that I'm aware of. The cheap option is to go to the Office of the Public Advocate's website and to download the power of attorney documents and to complete them from the, and you can do that through the online form. But I have to say that community legal centres are struggling to help people do them, and the form isn't straightforward. There are a number of options, so that complicates things because people have to think through the options. And so I'd like to say it is straightforward, but it is more complicated than that. And I think people have to give a bit of thought to the documents. It might be just a bit of paper, but boy, do they have ramifications if someone's going to refuse treatment on your behalf and you die. So it isn't something that's just a piece of paper. There's a huge responsibility goes into it and a lot of thought. But I agree, the legal profession, when they do them, often charge a substantial amount for this, and that prevents a lot of people from getting them.
I'll just come for a final comment from Karen Hitchcock. What drove you to write the article? Because to be honest with you, as I listen to this, I feel like there's a human rights issue here about what we're offering our elderly people when they're most vulnerable. And is that why you went to, as it were, the media and wrote something? What drove you to that step?
Yeah, well, exactly that. I mean, the human rights issue has been sort of transmuted into the human right of being able to choose, where really I thought that what was going on was it wasn't really that we were offering older people choice. We were sort of trying to narrow their choices and get them to choose in the way that we thought they should be choosing. I guess that was one of the reasons why I wrote it.
And just finally, palliative care within an acute care setting. Again, this is just an anecdote, and I won't go into it, there's no time, but I've been personally involved in a family setting with an elderly person dying within an acute care hospital in a manner that I thought was extremely sensitive, where a separate room was provided, a family stayed with him over a 3-day period with considerable support. But I have no idea how common that is. Do we know, do we have any evidence around how many acute care settings do end, and that I'm obviously talking there about the very end of life, but do that very end of life care quite well?
I think it varies hugely. So 5% of my patients die. Most of the deaths are expected, and we try very, very hard at the Alfred to give a separate room, and we have a fantastic palliative care. We have a fantastic palliative care service that can help us if the death the symptoms at the end of life become complicated. But I think that we still overall, that there are terrible deaths that happen in acute hospitals due to a lack of palliative care and a lack of palliative care training. I don't know what the figures are.
This woman just has to speak. I can feel her intensity, so we'll close with her. You want to stand up so people can stare at you?
My name's Louise Ty. I'm one of the nurses in community palliative care. So I was just listening to what you were saying about the advanced care, documents, but because they're live documents, if somebody changes their mind and they have the capacity to change their mind, then they could overrule that document at that time. My understanding is they're more useful if I don't have the capacity to make that decision, and then that's my wish. Therefore, if your concerns about, we're not going to treat someone because they might want it now, even though their advanced care plan says they don't want it, but actually if they're competent to make that decision and they've changed their mind, that advanced care plan would be disregarded anyway. So
I mean, it's really complicated, and on the wards I have to say that in an advanced care plan it's never clear. I mean, it's not something that says, I want this, I don't want that. Most of the time they come into effect and they say things like, I don't want to be intubated, when there's no way any ICU in a public hospital would even accept that patient anyway, so it's beside the point. It's only ever one piece of information amongst, hundreds of pieces of information that you get from the family, whatever the patient's capacity is at the time, the information from the nursing home or the GP or whatever. I mean, I'm not saying that I'm not saying that you shouldn't have one, not at all, but I just think that to make it a legally binding specific document is dangerous.
Well, ladies and gentlemen, you are the most precious people, because you got here really early, it's all been really deep, and you're still here. So forget the panel, clap yourselves. But I will ask you to thank Phil Grano, Dr. Karen Hitchcock and Dr. Rosalie Hudson for their contribution.